Good morning. Let me start by thanking Dr. Jasuja and Dr. Gaurav and the organizing committee of Avatar for inviting me to give this talk. So the title of my talk is Percutaneous Interventions, What Not to Do. Pathways to infinity. There are two pathways. The via positiva, which is the positive pathway. So last year I was asked to speak on percutaneous interventions, tips and tricks. So those were the do's. But this year I've been asked to follow the negative pathway and talk about don'ts. Demings, who was a pioneer in terms of quality improvement, and after his advice to Japan after the Second World War, he made this quote, and Japan became an economic power. It is not enough to do your best. You must know what to do, and in brackets I've put and not to do, and then do your best. So in the interventional lab, we deal with fistulas and grafts, and our basic procedures are angioplasties. Sometimes we deploy stents, and then we do thrombolysis and thrombectomies. And the thrombectomy thrombolysis incorporates often angioplasty with or without stent placement. So the first thing, you don't set sail without a compass. You have to look at operative notes and physical exam. So first you need to know, why has this patient been referred? Is there low blood flow, inadequate dialysis, which would suggest maybe an inflow stenosis, or prolonged bleeding, which may suggest an outflow stenosis. Difficult needle placement, maybe there's a stenosis in the body of the fistula. Operative notes are helpful because you may choose a balloon, so you need to know the diameter of the graft, type of the access. If it's a transposed fistula, you may have a stenosis in the swing site. Previous procedures are helpful. Radiographic images, previous locations of stenosis, balloon sizes used, and then finally a physical exam. There's poor augmentation, low flow, maybe there's an inflow stenosis. Pulsatile aneurysmal fistula, the Dr. Shenoy said, perhaps there's an outflow stenosis. So here is an example. Arm down, you can see it's a pulsatile fistula in the juxtaanastomotic area, but it's soft beyond that. When the arm is raised, fistula collapses except for that juxta segment. There's no collapse. So by looking at this fistula, you can plan your needle entry. You would prefer to come from above because you'll have much more room to maneuver and open a balloon. The next step is, don't rush in where angels fear to tread. A sentence from a poem by Alexander Pope. So a recently placed fistula or graft is usually a surgical issue, and the incisions and the anastomosis are fresh. So I try to avoid dealing with those accesses. Immature virgin fistula, where you can't even palpate the fistula, your chance of success is low. Local infection, redness, tenderness, patient has fever, avoid that access. And thrombosis in a fistula that's several days old, a week or two old, less likely because the clot is organized, the endothelium is very viable. And then finally, the giant fistula with a big clot burden. Fistula of this size with a huge clot perhaps should not be attempted in the interventional lab. Better to ask our surgical colleagues to remove that clot, and you saw a very beautiful picture in the previous talk. The next thing is, don't start the train without a track. So it's very important in the Seldinger technique that you are able to pass the wire all the way to the central veins. Sometimes in a clotted access, it's very difficult to you have to make sure that your wire is within the access and it's not outside. And secondly, the wire may get caught in points of stenosis. So That's where some tricks have to come in. You know, the tip of the wire could be bent, or you can use a torquing device and use a guiding catheter. It's shown here, you know, how to use a torquing device, and then in the right frame, you can see you can use a guiding catheter, either a straight tipped or a slightly bent catheter, so that you can get the wire across a stenosis. And this shows you, the track is laid out, you have the wire all the way where the arrows are pointing to the central circulation. And you can see some stenotic areas, you can work on those. The next thing is, don't push the envelope. Don't push a large volume of contrast in a clotted access, because there's danger of clots going in the wrong areas. So here is a fistula that is filled with clot. There's some flow in it, and you can see a stenosis in the cephalic arch. So if you have to push a lot of contrast, the clot could go backwards into the brachial artery. Other causes of arterial emboli is when we work and we put the Fogarty balloon into the artery. Here's the Fogarty balloon, you know, which is not it's a compliant balloon, and there's Dr. Fogarty, he's now into vines. So you put the balloon and you drag it through the access to establish flow. But in doing so, you may actually inadvertently move the fibrin plug into the brachial artery and cause an arterial embolus. The other situation where you could cause an arterial embolus is if you do a retrograde angiogram after you have declotted an access. In this, you occlude the access and you forcefully shoot contrast. If there are some clots in the access, they may go down into the artery. Now, frequency, fortunately, of arterial emboli is very low. In these two series by Dr. Bethard, in the first series, there were only 4 cases, and in the second, the incidence was like 0.38%. So these are arterial emboli that are symptomatic, you know, where the patient complains of pain. If you go looking for them, you may find a lot of asymptomatic emboli. So once that happens, you have some choices. You can use the same Fogarty balloon or an infusion catheter to try and retrieve the clot and pull it into the access. And you can put TPA. If that doesn't work, you have to call Dr. Shenoy into the case. And I have Dr. Tan from my institution. I always call him to do an arterectomy to remove the embolus. So here's an example of a clot that has gone into the brachial artery, and we have successfully removed with a Fogarty balloon, the very balloon that probably may have caused the clot. The other thing is to prevent pulmonary emboli. So if you have, as I said, a large clot burden, you have a higher chance of sending emboli into the central circulation. When you are doing a thrombectomy in a rather large fistula, you should park a balloon in the proximal part of the fistula when you are doing your pharmacological thrombolysis, and you are aspirating as much clot as you can until most of the clot is removed, and then you can deflate the balloon as shown here. So there is that case that I showed you earlier had a stenosis in the cephalic arch, the balloon is parked, and in the angiogram, now the balloon is released, all the clots have been removed. The next step is, don't be a fool with a tool. We are choose the right balloon. The balloon length should be such that it extends about 0.5 centimeter on either side of the stenosis. The reason is, if you use a longer balloon, you may be damaging healthy endothelium. The size of the balloon should be about 1 millimeter larger than the vein size, if it is a vein. But if it's an artery, you don't want to oversize it. You want it to be the same size of the artery or even smaller. So, and the pressures in the balloon, if it is in the vein, it's usually hyperplasia. And so you can go to fairly high pressures, all the way up to 30, 40 ATMs. But in the artery, it's usually atherosclerosis. So you want to use low pressures in the artery. And here is an example of balloon choice. You can see the lesion is about 3 centimeters long. It's almost an 80-90% stenosis. Adjacent vein is 7 millimeters. And you can see, as it's shown here, so you can choose an 8 millimeter balloon and 4 centimeters in length. So you have it across of about 0.5 centimeters on either side. And you can use the burst pressure 16. Many of us will go up to 20, perhaps 18 to 20. But beyond that, the balloon may rupture. Now, when you are doing especially a high pressure angioplasty, make sure that the wire remains in place and that you don't remove the wire. Because if there is a rupture, the wire will not cross that area, it will go out. So you leave the wire there, and there are some tips to prevent venous rupture and minimize hematoma formation. Start with the central lesions. So if you have a lesion in the central vein, start from there and then move towards the periphery so that you don't have high pressure in a recently angioplastied lesion. Second is inflate the balloon slowly and deflate it slowly. When you deflate it very rapidly, you get a rush of blood going across the lesion. And during deflation, you can cut inflow. So these are little points that may help in preventing venous rupture. But vein rupture does occur, overall 2% in most cases, more in fistulas than in grafts, more in transposed fistulas than in non-transposed fistulas, more in females than in males. Okay. So as I said, treatment, first thing you want to cut inflow. Better to lose the access than the patient. Okay. Open balloon at the site and try a prolonged angioplasty. Sometimes that seals the perforation. And then you have to choose stent deployment across the tear. And if you are not able to do all that, again, you call your surgeon friend. So here is an example of a transposed fistula, and this was a woman. 90% stenosis, successful angioplasty, but when the angiogram was done, you see that there is rupture. And the wire fortunately is across the lesion, so a stent was deployed with good success. The next thing is, don't let the horse out of the barn. So the first thing is, if you are going to deploy a stent, decide first, do you really need to open a stent? The lesions that need stents are, one is recoiling lesion. So you have opened it, it's a 90%, you opened it and it's back to 80%. You do a prolonged plasty, it comes back. That lesion may need a stent. Rupture, of course you need a stent. But recurrent stenosis is another reason that people place stents, and you have to make a decision, is it worth putting a stent, because even the stents will have intra-stent stenosis. But once you decide, the most common reason for stent migration, which is rare, is undersizing of the stent. The stent is undersized and you got good flow in the access, it will push the stent into the central circulation, and it's like a river. The veins become larger. So the stent is going to go into the heart and into the pulmonary artery. Here is an example of a stent that got out of the barn and has gone into the pulmonary artery. Fortunately, this patient was totally asymptomatic. The stent lodged in a pulmonary artery and didn't do anything bad for the patient. So an ounce of prevention is worth a pound of cure. So what can you do? First is, you choose the stent 1 to 2 millimeters larger than the vessel width. Put a long 260 centimeter wire all the way from the access into the heart, into the inferior vena cava, so that if the stent went loose, it would still be on the wire. And after you have opened the stent, you open a balloon to anchor the stent. And if the stent migrates, you need to have a bailout plan. And here are some examples here. In the left panel, you can put a wire, you have to put a big sheath, put a wire. Over the wire, you can put a balloon to sort of stabilize the stent, and then put a snare over it. And on the right, you can see a pigtail catheter through the stent and then a snare. So it can be complicated, but it can be done. You can pull the stent out. Other don'ts regarding stents is one is do not create a stentula. So what is a stentula? It's a access, a fistula or a graft where they have just placed so many stents that the whole access has now become a stentula. So instead of fistula, it's become a stentula. And now you have to access it through the stent, access to the stent. Especially do not place stents in the sticking segment of an AVF or an AVG. As in this case, stent is in the sticking area of the graft. And if you notice in the panel C, you can see the end of the stent. And the end of the stent is now actually, a piece of it is coming out of the sticking area. So this would call for definitely, this access would get infected. In addition, some patients do complain of pain when you access, put a needle through the stent into the And finally, do not jail a major vein, especially with a covered stent. So what do I mean by that? So here is a stent, and you can see it. It was placed in the subclavian, right subclavian vein going into the right brachiocephalic vein. But it somehow slipped, and the top of the stent is now in the internal jugular vein. And the stent in the lower portion is blocking the left brachiocephalic vein. So imagine if this was a covered stent, it would create a lot of problems. So the stent has to be placed, the length of the stent, it has to be placed precisely. And finally, do not flog a dead horse. What do I mean by that? There are some accesses, especially grafts, they have a life. They don't, and you can spend a lot of time trying to open them. But there is a point where you decide and you say, this is, I've done everything I can for this. So you can retain the arterial angiograms of the outflow vein, you can look at the inflow artery, and that is valuable information for the surgeon to place a new access. And of course here, some of our nephrologists are placing, and that's wonderful. So the take-home points are, the don'ts are, make sure that you familiarize yourself with the access before you go into and start doing the intervention. Sometimes I'm training fellows and they just they're so excited they want to go in and start working. But I think it's very good if you know the dimensions of the access, previous balloons used, locations of stenotic areas, and a good physical exam will go a long way. Guide wire is very important. If the guide wire does not cross the lesion, then I think you cannot, you should need to abandon the procedure, especially if you are doing, say, a thrombolysis, thrombectomy. The wire has to go to the central circulation. I gave you can have pulmonary emboli can occur. And in fact, if you do CT scans, there are studies showing that probably most patients have small asymptomatic pulmonary emboli. But you don't want to have a large embolus with a cardiac arrest on the table. So that's where you have to decide if it's a very large clotted fistula, let this surgical colleagues handle it. Arterial embolus is rare, but when it occurs, you need to recognize it. Patients will complain of arm pain, hand pain right away, and it can be addressed in the interventional suite. Choose the correct balloon size, balloon pressure. Know how to have a stent perhaps in the interventional suite in case the vein ruptures. Avoid stent migration and know when to quit. Thank you for being a very receptive audience.
Thank you, Dr. Kenneth, for an excellent overview of the don'ts of interventions, because knowing the complications is more important than going for any procedure. And I'm sure many of us are having questions from him. Questions, please?
So, Dr. Venkatesh, so the stents we use for vein rupture, can we use a bare metal stent or it has to be a covered stent always?
Not necessarily. You could put a non-covered stent, because once that stent is placed, the flow property of blood is such that it will work.
Okay. Even
A,
for
a
central-
non-covered stent will work if you have vein rupture.
Okay, even for a central venous rupture?
Central venous vein rupture, I do believe they should work. You know.
Thanks.
Dheeraj is here. Dheeraj, they work, right? For central vein rupture. Do you always have to have a covered stent?
No. So the basic concept of placing a stent is you have blood leaving the vessel because it's going to the place of low pressure. So by placing a stent, you create a conduit that's a low pressure conduit, and that's why it works.
Exactly.
So you don't need a covered stent for central or peripheral. Actually, it's better to avoid it if you can.
Yeah. So as soon as that area is opened up, you know, the flow just goes through and bleeding stops.
Okay.
It's worth trying a prolonged plasty, like 2 minutes, you know, 2 to 3 minutes, open the balloon and just, and that may itself stop the bleeding.
Okay, thank you, Dr. Kenneth, for an excellent overview.